The Women's Health Initiative, often called the WHI, was one of the largest and most expensive clinical trials ever conducted in women's health. It didn't just add to what we know about menopause, it completely changed how menopause has been treated. For more than 20 years now, the Women's Health Initiative has shaped how clinicians think about menopause hormones, how patients think about risk, and in many cases, whether menopause is treated at all. If you take care of postmenopausal women, you don't need another summary or a headline about the WHI, but I would recommend that you try to understand the original paper that started all this conversation. In this video, I'm going to read the original 2002 JAMA paper from the Women's Health Initiative Writing Group, and we're going to ask some simple questions about the text. Not gotcha questions, just the kind of questions that thoughtful clinicians might want to ask when one study ends up changing care for millions of women. Before we jump in, though, I'd like to give you a quick aside. Patients today are absolutely swimming in misinformation, especially about menopause and hormone replacement therapy for menopause. A lot of us spend a surprising amount of time just trying to undo the fear and hesitation that comes directly from studies like the Women's Health Initiative and some knock-on effects. If that's been an issue in your practice, there are some tools that can help. Visit my website at simplehormones.com/clarify to learn more about my Simple Hormones program and how it can help you bring clarity for both you and your patients. Now let's take a look at the paper itself. The full title of the study is Risks and Benefits of Estrogen plus Progestin in Healthy Postmenopausal Women, Principal Results from the Women's Health Initiative Randomized Controlled Trial. My first question starts with one word in that title, healthy. Were the women in the WHI trial actually healthy? Well, to answer that, we need to look at Table 1, the baseline characteristics of the patients in the study, which you can see here on the screen. The average age of the women in the Women's Health Initiative was about 63 years old. More than 70% of these women were overweight or obese. About 40% of the women were former smokers, and more than 10% were current smokers during the study. Over a third were being treated for hypertension. About 12% were being treated for high cholesterol. Based on what's actually in Table 1, what did the authors mean when they called these women healthy? And does that healthy tag line up with how we typically use that word in clinical practice? The average woman in this trial, as I mentioned, was 63 years old. The average age of natural menopause is around 51. That's pretty consistent. That means many of these women had been without estrogen and progesterone for more than a decade before they ever even entered the study. By 2002, it was already pretty well established that estrogen and progesterone do play an important role in cardiovascular health, bone, metabolic, and brain health. In fact, the main goal of the Women's Health Initiative Estrogen plus Progestin trial was to see whether or not adding hormones back to women who didn't have them made a difference, especially when it came to heart disease. So here's a question. What might more than 10 years without estrogen and progesterone have done to baseline risk before the study even started? According to the WHI paper, about 7.7% of the women had a history of cardiovascular disease. The primary outcome of the study was coronary heart disease, and that was defined as non-fatal heart attack, as well as death from coronary heart disease. When you put the numbers sort of side by side, something starts to feel a little bit difficult to reconcile. At baseline, about 1.6 to 1.9% of the women already had a history of myocardial infarction. That's before the study even started. During the trial, non-fatal heart attacks occurred in about 0.23 to 0.3% of the women. Deaths from coronary heart disease occurred in about 0.06 to 0.07%. So when you actually run the numbers, there were roughly 4 to 6 times more heart attacks documented before the study than during the study. So the practical question might come down to this. Does this really look like a pure primary prevention population? Or are we maybe looking at women with meaningful pre-existing cardiovascular risk who are still labeled as healthy? In the estrogen plus progestin arm of the Women's Health Initiative, the authors reported a 26% relative rate increase in invasive breast cancer. The hormone therapy used in this trial was conjugated equine estrogens plus medroxyprogesterone acetate, often shortened to CEE plus MPA. The paper also says that the breast cancer finding almost reached statistical significance. Well, I'm not a statistician, but when the report says the rate of breast cancer risk almost reached statistical significance, isn't that the same as saying it did not reach statistical significance? So here's another question. If a result doesn't quite reach statistical significance, how are we supposed to use that information clinically? I'm not dismissing this finding. I'm just asking how an almost statistically significant finding should guide our real-world decision-making with real patients. Now let's talk about how that risk was presented. The relative rate increase was reported as 26%, or a hazard ratio of 1.26. But the absolute rate increase was 8 additional cases per 10,000 woman years. That's an absolute increase of 0.08%. So how should we think about a 26% relative increase when the absolute difference is 0.08%? I'm not saying the risk doesn't matter, but it's about understanding what those numbers actually mean when we're sitting across from a patient. The WHI paper also states that there were no differences in overall mortality or causes of death between the two groups. The 26% increase in relative risk was based on breast cancer diagnosis, not breast cancer deaths. That doesn't mean diagnoses don't matter, but it does matter when we're trying to understand the overall impact of hormone therapy risks and benefits. All the questions that I'm asking here come straight from the data and the language in the original 2002 JAMA Women's Health Initiative report. They're just meant to slow us down and to help us to think more clearly about what the WHI says and what it doesn't say. How studies like the Women's Health Initiative are framed and talked about, that has real consequences, especially when those conversations shape menopause care for an entire generation of women. If you want to understand how we ended up where we are today with menopause and hormone replacement therapy, that story really matters. And a lot of it has to do with this book, Estrogen Matters, by Dr. Avram Blooming. That's a teaser for my next video.